Hello everyone, I'm Enyu from Department of Radiology, West China Hospital, China. I'm presenting to you our research, quantitative analysis with time-dependent diffusion MRI for assessing WHO ISUP tumor grade in clear cell renal cell carcinoma. Renal cell carcinoma is a leading global malignancy, with clear cell subtype accounting for 75% of cancer-related deaths. 30 to 40% of clear cell renal cell carcinoma cases metastasize or recur early after surgery. These aggressive tumors are characterized by increased nuclear size, prominent nucleoli, and high cellularity. Histologic characterization before surgery is crucial for precise treatment, but remains challenging. Time-dependent diffusion MRI offers a potential solution by combining oscillating gradient spin echo and pulsed gradient spin echo methods. This technique enables the exploration of the apparent diffusion coefficient dependencies at short diffusion times, enabling microstructural insights into cellularity and cell diameter. This model has been comprehensively validated through computer simulations, cells, animals, and clinical human imaging. Recent studies have indicated that parameters from time-dependent diffusion MRI are associated with pathological characteristics, including pathological grades in various cancers, such as glioblastoma, neck, breast, prostate, and endometrial cancers. In this study, we aimed to assess the potential of time-dependent diffusion MRI parameters in predicting ISUP grade in clear cell renal cell carcinoma and investigate the correlation between these imaging parameters and the nuclear fraction on pathology. In this study, we conducted a retrospective analysis of a prospective cohort. This cohort contains consecutive patients with suspected renal cell carcinoma on CT. They underwent pretreatment time-dependent diffusion MRI examination on a 3 Tesla Philips Ingenia Elition MRI scanner. The inclusion criteria for this study were as follows. First, age over 18 years. Second, surgery performed within 4 weeks after imaging examination. And third, histopathologic confirmation of clear cell renal cell carcinoma following surgery. The exclusion criteria consisted of first, recurrent tumor, second, any prior treatment for clear cell renal cell carcinoma before MRI, third, missing clinical or pathological data, fourth, poor image quality or significant artifacts, and fifth, solid tumor components smaller than 100 square millimeters on T2-weighted imaging. The time-dependent diffusion MRI data were fitted to a two-compartment model named imaging microstructural parameters using limited spectrally edited diffusion impulsed microstructural quantitative parameters including cell diameter, intracellular volume fraction, extracellular diffusivity, and cellularity were then estimated. Fitting was performed using least squares curve fitting. Diffusivity maps were calculated at each diffusion time. Two radiologists annotated the three-dimensional solid tumor area on the PGAC image, excluding areas of necrosis, cysts, hemorrhage, or calcification. The mean value of RI area was used for further analysis. The ISUP grade was determined using the HE stain slides. A pathologist blinded to the MRI findings reviewed the slides. The tumor was classified as high-grade tumor if the ISUP grade was 3 or 4. Otherwise, the tumor was classified as low-grade tumor. Digital slides were obtained from 92 patients. For each slide, a rectangular ROI was placed to cover the largest tumor area and was cropped into patches of 2048 multiplies 2048 pixels. These patches were processed using an open-source pre-trained neural network named HarvardNet to achieve nuclear segmentation. The nuclear fraction on pathology was calculated as the ratio of the total nuclear area to the total tissue area across all patches on a given slide. As a result, a total of 138 patients were analyzed in this study, including 90 low-grade clear cell renal cell carcinomas and 48 high-grade clear cell renal cell carcinomas. The ISUP grade was positively correlated with intracellular volume fraction and cellularity, and negatively correlated with extracellular diffusivity at 0 Hz and diffusivity at 70 Hz. Compared with high-grade tumors, low-grade tumors exhibited lower cellularity, lower intracellular volume fraction, higher diameter, and higher extracellular diffusivity. For diffusivity, lower-grade tumors exhibited high diffusivity at 0, 16, and 33 Hz than in high-grade tumors. The intracellular volume fraction demonstrated the highest discriminant power with an area under curve of 0.943, followed by cellularity, which exhibited an area under curve of 0.931. For diffusivity maps, diffusivity at 0 Hz demonstrated an area under curve of 0.829. The DeLong test revealed that intracellular volume fraction and cellularity were more effective than diffusivity at 0 Hz in distinguishing between low and high-grade tumors. Subgroup analysis demonstrated that these quantitative parameters had consistent grading performance across various tumor sizes. Digital slides from 92 patients were acquired and segmented by HarvardNet, comprising 3 grade 1, 55 grade 2, 28 grade 3, and 8 grade 4. For each slide, 3 to 1,939 patches were analyzed, covering a median total area of 118 million square microns. The Spearman test revealed a strong correlation between intracellular volume fraction derived from the impulse model and the nuclear fraction on pathology. Our study has some limitations. Firstly, despite efforts to match imaging annotations with pathology, perfect correspondence cannot be guaranteed. Secondly, the relatively small number of ISUP grade 4 patients enrolled in this study may have reduced the reliability of some findings. Future studies should include larger cohorts to provide more robust conclusions. So here is the take-home messages. Firstly, low-grade clear cell renal cell carcinomas showed lower cellularity and intracellular volume fraction, but higher diameter, extracellular diffusivity, and diffusivity at 0, 17, 33 Hz compared to high-grade tumors. Secondly, intracellular volume fraction and cellularity had the highest diagnostic accuracy in distinguishing tumor grades, outperforming the other parameters with consistent performance across different tumor sizes. Finally, a strong correlation was found between the intracellular volume fraction derived from the impulse model and the nuclear fraction on pathology, validating the image-based assessment of tumor microstructure. Thank you for listening.